Here, can you see my screen?
Yeah, we can see it, sir.
Let me, sorry, let me just interrupt and restart because I had just one problem. Good, let me go here. I think I have to go keynote. Okay. Reproduce. Good. Good enough. Can you see now?
Yeah, we can see it, sir.
Good. I'm from São Paulo, Brazil, from Nyon Institute. These are my disclosures. I try to be no longer because I know for you it's not early, it's very late. Then I'll talk about open fractures of the shoulder. Here I can everybody talk about the Castillo-Anderson classification, and I think it's the main thing in this issue of open fractures. But we have to take a special care in shoulder and elbow for type 1 and type 2, because you will almost always work like a closed fracture. And type 3, it's mostly different, but not so. Then we can better understand. Some people talk before about the treatment of antibiotics. That's very important. Begin using it ASAP. The first 6 or 8 hours are critical to begin antibiotics. When you begin antibiotics, you stop counting time to the surgery. But then it's very important, more in the still 1 and 2, the antibiotics very early. Surgical intervention with wound debridement and cleaning by using 10 liters of saline. And debridement needs to be as aggressive as the contamination is. This is the important point for all open fractures, mostly in shoulder, because you can go from the hell to heaven in 1 minute if you don't debride the one thing a suitable way, in a suitable way. Risk factors for infections. We saw here that some of these patients with infections, smokers have more infection after an open fracture. Open fractures of Castillo 3, it's expected to be more frequent after the surgery than grade 1 and 2. Internal fixation, but not doesn't have statistical significance. And we have high-grade open fractures demonstrate an increased risk of infection with delayed debridement. Then the early debridement is the key for a good result in every open fractures. Treatment for Castillo 1 and 2, as I told before, the patient underwent antibiotic therapy and surgical cleaning in a reliable way. Regular treatment can be followed. Then the normal treatment for proximal humerus fracture is 5% of fractures, third most frequent over the 65, 3% in 4 parts, and woman 3-1. Then it's a different fracture. Direct fall, 80%. You have a varus compression of the humeral head against the glenoid, compressive strength on the humeral neck, tension of the rotator cuff on the tuberosities. And there are other mechanisms, fall and adduction and internal rotation with valgus compression of the humeral head against the glenoid. There are some differences in treating these fractures. And we have to take care because the shoulder has a lot of soft tissues that can have an important play in when you do the stabilization, when you do the surgery. You have the pec major bringing the humeral shaft anterior, you have the subscap, you have the suprascapularis, infraspinatus, and then the supraspinatus, infraspinatus, sorry. And you have also so many structures, neurovascular structures, very, very near. Then we have to know very well the vascular anatomy and know that we will need some vascular surgeon in our surgeries many times. It can be very common. And we know that the anterior circumflex artery can, in 85% of the humeral head, be very important, in posterior circumflex artery in 64%. But the posterior circumflex artery is more related to humeral head preservation after a fracture. Then it's important to know if your fracture goes to the humeral, the anatomical neck, because it can cross this artery and you can have some problems, in the late problems. Humeral head fractures, 10% associated with other lesions. Rotator cuff tears, you have rotator cuff tears for 60-year-olds. You'll see some case here, I'll show you, of this kind of fractures. More than 50% of time in more than 60 years old. Neurological problems are in 67%, most of them transitory, and most of them of the axillary nerve. Then we have a delayed rehabilitation for some patients with these problems. Suprascapular dissections, not common, is axillary artery lesion. We have many classifications. I used to have to use this in my day-by-day. It's the NIR classification. I think most of you can use the same or use the LEGO classification, Hertel. But for me, NIR is going well for all my surgeries. And some predictors, predict head and anatomic neck fractures because of the circulation of the circumflex arteries that can be torn. Humeral head angulation of more than 45 degrees, fractures of 3 or 4 fragments, tuberosity displacements of more than 1 centimeter, and glenohumeral dislocation. Here is a patient. You can see the CT scan. Here is a patient that had an open fracture, a very displaced humerus, but we have Agustilo once, just a small opening of this fracture. Then I just clean it up and inserted the regular final plate, and it's done. This is the case. If you have Agustilo 1 and 2, you can have a definitive ORAF. Oh, it's not working. Good. But if you have Agustilo 3, you can do the damage control using external fixation or just cleaning and waiting for the second step to see if you don't have any infection. It's possible to do. And here we have some papers that can make us have this decision to use the external fixation, but you have to take care because the axillary nerve is so near. This, particularly this fixation of this book, I wouldn't never know because it's so near of the axillary nerve and I would be very afraid. But other better locating can work better. Here, it's not the case of open fracture, but you just to make you know how to do this external fixation. And you have to take care with floating shoulder. Same way with gunshot, it's not possible sometimes to make more than clean it with some clean it the better we can, and wait how can we treat after. Then first of all, you avoid infection on these fractures. But even if you think in arthroplasty, it's possible to do in open fractures if you have Agustilo 1 and 2. There is a paper very interesting with no difference of ORIF and arthroplasty. And when you saw this, we start doing these surgeries for this kind of patients that had age of more than 70. These are indications for reverse. Then I love to do reverse more than Hemi or total. And even in youngsters, I am doing this now. And here is head split fractures that can be useful to do prosthesis. If you have Garcia 1 and 2, you don't wait. You can do in the first surgery. The first surgery you can do this. This is a Hemi arthroplasty. I don't do this anymore. Now I'm going to do just this kind of surgeries that are reverse. This is a 65-year-old male with still 1 fracture with a split head fracture. Here.
Prof. Carlos, I'm so sorry. The slides are stuck on treatment damage control Gastello 3. The slides are not running.
Not running?
Yeah.
We are still in treatment of displaced 2-part fractures.
This is now damage control floating shoulder?
Yeah. Damage control Gastello 3.
Yes, now...
With the external fixator, with the X-fax on the displaced 2-part fracture humerus, proximal humerus.
Let me see. Are you seeing now the reverse shoulder arthroplasty setting? Is it?
No.
No? Then I'm...
No, we see the X-fax in the displaced 2-part fracture.
Okay, I will just doesn't share my screen and I'll return. Let me just see here. 4 parts here. Sorry for this inconvenience.
No problem at all.
Happens again, please make me know.
Okay.
Let me just, I will share my screen because I think it can be better. Can you see now?
Not yet.
Floating shoulder. Are you seeing?
Not yet.
For me, it's like it's sharing. Let me see again. Let's place it 2 parts. Can you see floating shoulder?
Not yet, sir.
Oh God. Let me try again. Interrupt. Start over again. Keynote. Sorry, these technological things happen all the time.
No problem at all.
Can you see? Floating shoulder?
Not yet. Yeah.
Yes?
Yes.
Okay, good enough. Then floating shoulder, you can use this external fixation, and after you plan your fixation, your definitive fixation. But in Garcia 1 and 2, as I was talking before, there are no difference in hospital for ORIF or arthroplasty of open proximal humerus. In Garcia 1 and 2, Garcia 3, you have to take care, and Garcia 3, generally in shoulder, you have damage of the artery, you have damage of the nerves, then it's a big problem in Garcia 3. But we have a lot of soft tissue around the shoulder, then the shoulder is well protected, and it's the good thing about the shoulder. But as I was talking for you before, reverse shoulder arthroplasty can be used even in this case, the head split fractures and another fractures. Here is starting talking about Hemi, but I don't do it anymore, even in youngster patients. And here is a case, 6-year-old male Garcia 1. Can you see here the fracture, the split head fracture with some Garcia 1? No problem. We cleaned the surgery and then start doing the prosthesis. This was the exposition. And for these patients, I like to use the uncemented diaphysis fixation. Sometimes for me, it looks very good because I don't have to use any cement in this case. And I like this prosthesis because for fractures, I prefer to use inlay prosthesis. Generally, I like to use onlay prosthesis. Then makes sense for me because he fulfills all the bone loss you have sometimes, or the fractures, and can work very well. Here, the prosthesis, you have a fixation with no cement. In this case, I'll show you some cement fixations because you have some other problems. And here's the patient, post-operative. I don't insert the subscap. I make the retroversion 30 degrees, and it's okay for me. This is how I join all the tuberosities, and it's done. This is the patient. And here we have another patient with Garcia 2, 65-year-old 2. Here is a lady that had this problem. Then we have to do a very huge approach to clean it up, to remove the head that was very far from the shaft, the humeral shaft. And, oh, sorry, you can see here the prosthesis inserted after surgery. A detail for fractures, for open fractures, and whatever fracture you do for prosthesis, you have used your glenosphere bigger than you can, because it's less predictable than making a prosthesis in a regular way. Here, another old lady, 82 years old, female, active, and Garcia 1. But see this fracture. This was the fracture of this lady. This lady doesn't have a high, this doesn't have, how can I say, strength, force. This is not a Garcia 3, but has many fragments because her bone is not so good enough. And in this case, I prefer to do some cerclage, and here is the final result of the prosthesis. Then prosthesis can be done, yes, in Garcia 1 and 2. Garcia 3, I would like to wait a little. And what about the civilian gunshot injuries? There's a paper telling that you just need, if you don't have to do anything more, if you don't have so many displacements, this study supports that you can just do nothing, just do the antibiotic therapy, and it's done. But it's not my practice. I prefer to clean the open fracture anyway, but it can be supported now by these papers. Clavicle is the same way, doesn't change anything. Just change the fixation method, nothing more. This is displaced fracture, and just change the method of fixation. Nothing to add for this, or even for scapular fractures. But you need to understand that scapular fractures, most of them are not surgical. We can just make a surgical clean of this surgical wound, of the wound, and it's done. But some case, when it goes to the articulation, it's better to fix this kind of fractures. I'd like to thank you very much for invitation, and now I'm open for any questions you have. I hope I have fulfilled your expectations.
Thank you so much. Thank you so much, Dr. Garcia, for this very interesting talk. Thank you so much, and for being with us tonight. Thank you so much.
Okay.
Dr. Rami Zahar from Munich, Germany, is the moderator with Dr. Garcia. Dr. Rami, you are with us?
Hello, my dear doctor. It was a very interesting presentation from your side. I really enjoyed it. I have a couple of questions. I can understand you with the comminuted fractures of the head of the humerus. It's most probably better to do an arthroplasty. But do you do the arthroplasty in 6 hours in open fractures, or you just wait and you plan it you make a planning for the reconstructive surgery with the arthroplasty?
It's a very good question because in Gustilo 1 and 2, I generally do before 6 hours. If you have before, if you've done before 6 hours, it can be done. But if you have more than 6 hours, I think you can take more care. If you don't have antibiotics before, and if you have the Gustilo 3, I don't recommend to do this kind of surgery. These are not the common. These are surgeries that are, how can I say, it's the common surgeries, but for mostly of cases, I think everyone will, most surgeons will don't have this time, the prosthesis available on this time. Then better to wait for 3 days, 4 days. You just clean the fracture and do the prosthesis after. I think it's good to do the prosthesis instead of other fixation in some case, because the first shot's the best shot, and if you haven't done another fixation and you fail, and you will fail if you have a bad indication, then you have to manage a problem. You have to manage a second surgery with failure that give more bad results than others.
Exactly, I do agree, because some of these cases come on the weekends, and I don't think that most of the hospitals have on the shelf the custom prosthesis or a long shaft prosthesis, especially for the reverse shoulder prosthesis.
Absolutely, I think we have this problems. The one patient was she came very early with 2 hours of the accident. Then we could do this very quickly, but it's not the common thing. It's not the common way. Another thing is that we can stop counting the time when you do the antibiotics. There are some papers that support that. You can stop counting time using antibiotics in case of Gustilo 1 and 2 for some fractures, some specific fractures. Then we can do that. We did one of these patients this, and we did the surgery in 8 hours, not in 6. But I know this consideration is very important, because I think not all places you can have this velocity. Here I work in the City Lebanese hospital that's very quick, and Moria that are very quick, but it's not the regular for every surgeon.
Exactly. And about Gustilo 1, you give a single shot of antibiotics, or you give for a couple of days?
I give a single shot. If you wait more 6 hours, you give more shots, 1 shot each 6 hours. But those are the initial shot is twice the current dosage of the antibiotics.
So in the range of 6 hours after the injury, you will be satisfied with with 1 single shot of antibiotics. I think that will be sufficient, especially in grade 1, right?
Yes, first 6 hours is very okay. For me, it's very okay.
And you do a priming debridement or something, even though that you're not planning the surgery on the same time, or you just leave it and satisfied with a single shot of antibiotics?
I do debridement all time, even in the first surgery. I debride as is possible. The most aggressive the fracture is, the most aggressive your debridement needs to be. The most aggressive the exposure, the open of the fracture, or the Gustilo type of the fracture is, the most aggressive is your debridement. Yeah. This is how I work. I had no problems generally, but I had one infection after, but not with prosthesis. But we have to take care. These patients need to see a lot of times, and it's not easy to manage.
Yes, of course. It's always a dilemma. And as about the 82 years old lady, you preferred not to cement the prosthesis, right?
I prefer never cement the prosthesis. In this case, I had to cement because the prosthesis I had was one that, in the case I showed you before,
Yes.
was a cemented prosthesis of 8 years. The uncemented was of a 65, but I prefer whenever I can to use non-cemented prosthesis. But as I told you before, this was the prosthesis I had in my hand at this time, and then I was a cemented for the 82 years old lady. The other prosthesis for the 65 years old guy was uncemented. Then I prefer uncemented anyway.
And you prefer in the younger age, about 55 or 60, not the anatomical or the inverse shoulder prosthesis?
I think it's a good question because it doesn't have a good answer. Because
it's always a big discussion because we have always that discussion. At 55 years old, they have very comminuted humeral head, and we say we do an anatomical or an inverse. And some authors say you cannot stabilize the rotator cuff muscles on the anatomical prosthesis. Just like to know your opinion about it.
Let me just tell you, because I think if the rotator cuff is okay, if you see the rotator cuff okay, 15 years old, you can do Hemi, or I don't like Hemis in truth, I like total, but I prefer totals that I can reverse after times, like the Zimmer one is one, the Arrow prosthesis is other that you can do the total, then you can just change some small pieces and make a reverse prosthesis. But there are some papers, and I have a patient with the youngster patient I have with reverse, I inserted him in 36 years. He has 36 years, a very young guy with a very bad complication, and is doing well. I don't know if in the future we'll see the reverse and tell, why didn't you do it before for the patient? And there is a paper, I think it's from Pascal Bolo, that shows the reverse prosthesis has better bone integration of the tuberosities than total common reverse prosthesis, because don't have so many forces coming across the rotator cuff.
Okay, so I have some questions from my colleagues. Dr. Rami Sharif, he is asking about your reference about the humeral height to implant the prosthesis in case of first comminuted proximal humerus, and what do you do to the glenoid if the glenoid comminuted too?
Yes, this is a very good question. First question about the reference. Sometimes you don't have so many reference, then it's a problem. The reference sometimes is the other side. Then you can have templates or electronic templates that you use, comparing both sides. Then it's good to do some X-ray of the other side of the patient, compare and insert the template, see the difference, because it's not easy to know the correct height of the prosthesis. No? Then you have to be aware and maybe sometimes be prepared to use some polys, so bigger polys, and to avoid some instabilities, it's good to use some bigger glenospheres in case of fractures. It's my advice to use bigger glenospheres for fractures, smaller for normal surgeries, for all fractures, yes. And in case of glenoid, this is a very complicated case. You can maybe doing 2 times in 2, depends on the glenoid fracture. There are some prostheses like arrow that you can insert a screw from anterior to posterior or posterior to anterior. If you have a fracture, longitudinal fracture of the glenoid, you can use the prosthesis anyway using this screw, but generally I do in 2 times the surgeries. I make first, prepare the glenoid, and after I do the prosthesis. I don't do in the same time generally, because generally it's so challenging.
And maybe that's the last question for today or tonight. From Dr. Ibrahim Kamar, he's asking why we're not using a Hemi prosthesis with convertible components.
I really don't like Hemi, because when you convert, and I believe I will convert this prosthesis sometime. As in the hip you don't use, you prefer, now people prefer to do a total than a Hemi arthroplasty. I think shoulder is going the same way of the hip. I think it's easier if you have a convertible prosthesis, because Hemi arthroplasty a lot of times will make some tragedy in the glenoid side, and then to make a revision, if you have a reversible primary, you can do better if you have a reversible than if you have a Hemi in the future. Because you can, when you make a prosthesis in a patient, you have to know and you have to think, you see the patient in the future, and you have to make a revision in this prosthesis. This is my way. I prefer this way. But it's not wrong to do a Hemi. I have done a lot of Hemi arthroplasties, and I had a lot of osteoarthritis of the glenoid because of the Hemi arthroplasties with bone loss. And it's not a good thing to manage in the future. What do you think about it?
And another question, do you like to use the external fixator as preliminary fixation, or sometimes you use it as a definitive fixation?
It's a good question. Depends on the patient, how the patient is feeling, how you could achieve the how can I say that you could achieve the good fixation. You could reconstruct the articulation. Then, if the answer is yes, you can do as a final fixation, a final synthesis. But if your answer is not, then you can change. But there's no problem in keep it. I don't mind if I do and I feel it's okay. I keep the external fixation, no problem at all.
There's other 2 questions that I think you answered them in between. Why uncemented? I think because of infection rate, and for revisions, it's easier to do it with the cementless.
Yes, for me, I prefer all time to do uncemented.
Yes.
I don't know what you prefer, but for me, uncemented is the best way to go. Unfortunately, we don't have so many cemented prostheses that goes to diaphysis. Okay, this prosthesis I showed before was Lima prosthesis that is uncemented with diaphysis fixation. That's very good. That works very well. But not at all times we will have prostheses that have this cementation. For fractures, generally prostheses are, we use prostheses of metaphysis fixation, and are not so good for fractures uncemented sometimes.
Yes, of course. Thank you very much, sir, for the interesting presentation. Thank you for your time.
Thank you so much, Dr. Garcia, for being with us tonight. It was a pleasure, sir.
It was my pleasure.